Welcome to the fifth meeting of the Budget Review Subcommittee on Health and Family Services. Just a reminder that members must be present in person to be counted, no remote attendance. The meeting materials were put online and are available there. And at this time, we'll have the secretary call the roll.
Senator Berg, Senator Titchener, Representative Duvall, Representative Fleming, Representative Johnson, Representative Raymer, here. Representative Wilner,
here.
Representative Wilson, Senator Mays Bledsoe, Senator McDaniel, Senator Meredith, Representative Bowling, Representative Bray, Representative Heverin, Representative Moser,
Here.
Representative Petrie, Co-Chair Williams,
Here.
Chair Richardson.
Here. All right, thank you so much. Next, we'll have the approval of the minutes for the September 17th meeting. Do I have a motion? My first is Senator Berg, and second with Representative Williams. Thank you so much. Before we go too much further, I do want to introduce Sarah Rome, sitting to my right. Welcome her to the Budget Review Committee, and thank you for all the help that she has done and will continue to do in the future. So welcome, Sarah. Also, you might have gathered this a little bit last time. I'm going to be a stickler for time, and we do have a lot on the agenda today. So I ask your forgiveness now if I cut you off, to not take offense. Everybody has prepared valuable presentations. And as I sit here and continue to waste time on that exact fact, we'll move on. First up, first presentation this morning, we have, we're going to start with Representative Amy Neighbors, okay? And Taylor Williams with Pharmacy Association to discuss a wonderful bill that I'm biased for, a pharmacy parity bill. Thank you. It just, you know the drill. Say your name.
Sir. For the record, I'm Representative Amy Neighbors, proudly serving the 21st District. Mr. Chairman and members of the committee, thank you for the opportunity to present today on legislation I intend to refile this coming January. Many of you will recall my recent testimony before the Health Services Committee regarding legislation I filed last session, House Bill 3, and its companion measure, Senate Joint Resolution 26, which was enacted. I want to express my appreciation to those of you who have already offered your support and shared encouraging feedback. To avoid repeating what I've previously shared, I'll get right to the point. This is not new legislation. In fact, as many of you know, it has now been 6 years since the original proposal was introduced to ensure that Kentucky pharmacists are reimbursed for providing clinical services they are already authorized to perform. The General Assembly has already enacted to secure commercial insurance reimbursement, but Medicaid remains out of alignment. The legislation I will refile in January, formerly House Bill 3, seeks to close that gap. This legislation is very straightforward. It does not address any aspect of dispensing activities or prescription coverage for Medicaid recipients. It does not expand Medicaid, broaden the pharmacist's scope of practice, or create any new services. Rather, it simply ensures that pharmacists, like other non-physician providers, are fairly reimbursed for the clinical services they are already authorized to perform and are currently providing. At present, Kentucky pharmacists are not compensated at the same rate as other non-physician providers for delivering identical services. This bill is about achieving cost savings, improving access to care, and producing better health outcomes. Additionally, it includes language to maintain flexibility should future federal changes occur, ensuring that Kentucky is not locked into unintended obligations. Senate Joint Resolution 26 directed the Cabinet for Health and Family Services, Department for Medicaid Services, to report to the LRC on House Bill 3, including potential costs, impacts, savings, and access considerations, using evidence from other states where pharmacists are reimbursed for these clinical services. The Cabinet submitted that report on August the 1st. Their findings were clear. Data from every state that has enacted similar legislation shows Medicaid either already saving dollars or trending toward measurable cost savings. Implementation would require only moderate administrative adjustments with minimal upfront investment, primarily to update software and add billing codes. The estimated one-time implementation cost is $128,050, the same figure reported by the Cabinet last session. While every dollar matters, this represents an insignificant investment, just 0.006% of the total Medicaid budget, or roughly half a penny for every $1,000 in Medicaid spending. In return, the program would realize greater long-term savings and improved outcomes. I have submitted the necessary budget request forms on the House side to ensure this remains under consideration during the budget process. Pharmacist provider care for minor ailments is significantly less costly than treatment in other settings, while expanding access to care and improving health outcomes. Kentucky is well positioned for this model, with pharmacists serving communities in 119 of our counties. Patients treated by pharmacists for minor conditions receive equally effective care as from other providers. Moreover, pharmacist involvement has been shown to improve chronic disease management for conditions such as diabetes and hypertension. This requested change is consistent with similar adjustments that have been made to our program in the past. It does not require anything extraordinary or special to implement, no more than any other change enacted by the General Assembly or the Cabinet. Nor is it unique. Several other states have already adopted comparable legislation and received federal approval. Should this legislation pass, the General Assembly will need to acknowledge through its passage that it authorizes the Cabinet to take the necessary actions required under House Bill 695 enacted last session. This will allow the Cabinet to submit the corresponding state plan amendment and have sufficient time to update system codes to support implementation. Before I turn it over to our pharmacists, I respectfully ask for your support of this legislation when we reconvene in January. With that, I'll invite Taylor Williams to share remarks from the perspective of Kentucky's pharmacists.
Thank you. My name is Taylor Williams. I'm a pharmacist and the Director of Government Affairs at the Kentucky Pharmacists Association. Thank you, Mr. Chairman, committee members, and our legislative sponsors for allowing me to speak today. On behalf of the whole pharmacy profession, I am here to say that payment for pharmacists' clinical services is our highest legislative priority. As Representative Neighbors stated, and simply put, this legislation ensures that pharmacists can be paid for clinical services that we are already trained and authorized to provide under our existing scope of practice. Right now, other non-physician providers get paid for these same services, but pharmacists do not. Representative Bentley's bill enacted years ago did fix that on the commercial side. However, Medicaid still does not reimburse pharmacists for services that it already pays other providers to deliver. Our proposed legislation does not expand pharmacists' scope of practice. Our pharmacists here in Kentucky are highly trained and qualified to provide all of the services within our scope. It does not expand the services covered under Medicaid. Pharmacists are only seeking payment for the services that Medicaid already pays other non-physician providers for. And it does not expand the Medicaid rolls. It does not make more patients or make existing patients sicker. It simply adds another provider, and one that may come at a lower cost than other options. This legislation does show cost savings and improved access to preventive services and quality care. 35 other states have already enacted the same or similar legislation. The Senate Joint Resolution 26 report reviewed more than 23 studies and highlights the benefits to our healthcare system based on real results seen in those states. The data does not lie. All data from the 35 states who have already passed their own versions of this legislation has shown savings to Medicaid or trends towards saving Medicaid dollars. As we look at the healthcare deserts in our own state and consider the strategies that we can use to tackle the systemic challenges and shift our culture to disease prevention, the data shows that patients see their local pharmacist up to 10 times more frequently than other healthcare providers. With 119 of our 120 counties in Kentucky having at least one pharmacy, our pharmacists are already uniquely well positioned to be proactive in pursuit of better healthcare outcomes in the Commonwealth. The changes needed to implement this legislation upon its passage are simple and routine. The Cabinet will be required to submit a state plan amendment or SPA, as 35 states have already done. Upon federal approval, the Cabinet will be required to update their existing system to allow pharmacist billing for covered service codes. Any other steps required to implement this bill will be the responsibility of the Kentucky pharmacists advocating for its passage. This legislation is worded as such to ensure that as any changes to Medicaid may occur at the federal level, the Kentucky Medicaid program is not locked into any unintended obligations and will not need further General Assembly action. This legislation only impacts the medical benefit and has no bearing on the pharmacy medication dispensing side of the Medicaid program. On behalf of all of Kentucky Pharmacy, our more than 5,000 licensed pharmacists, and your constituents, we ask for your support and passage of this returning legislation in 2026. Thank you all again.
Thank you so much. Do we have any questions from our members? We do not. Thank you. Well done. Next, the item on the agenda we have, she's already staying there. Representative Neighbors, Senator Stephen Meredith, Dr. Whitney Jones, Melissa Carrier, regarding the Kentucky colon cancer screening program. Again, please just identify yourselves. Make sure your green buttons are on. Two seasoned professionals at the table. I think we'll do well.
Yeah, hi, I'm Dr. Whitney Jones. I'm the founder of the Colon Cancer Prevention Project and the past chair of the Kentucky Colon Cancer Screening and Prevention Program.
Representative Amy Neighbors, 21st District.
Melissa Carr, Executive Director of Kentucky Cancer Link.
And I'm Steve Meredith, State Senator for the 5th District of Kentucky and Chair of our Senate's Standing Committee for Health Services, also a member of the Kentucky Colon Cancer Screening and Prevention Advisory Committee, and had the privilege of kicking this off this morning. And it certainly is an honor to be here. You know, I know we're here with the purpose to consider appropriation requests for the upcoming budget, but I hope we take just a moment to celebrate the success of this particular program. It started back in 2003. At that time, we were 49th in the nation in colon-related deaths. And because of the work of many dedicated healthcare professionals, but particularly because of Dr. Jones and his commitment, we're now 20th in the nation. And been able to do this with just a minuscule investment from our Commonwealth. The appropriation we gave the last budget session was right at $1 million. We're saving $67 million a year through that appropriation. But even more importantly, we're saving over 1,000 lives each and every year. And the appropriation request that they're asking, the increase they're asking for this next year, it truly is minuscule. Many of you heard me say before that one of my greatest frustrations as a legislator is we never take the time to measure the cost of doing nothing. And even though we've seen great improvement in colon cancer screening and reducing deaths, the work's not done yet. We particularly have problems in eastern Kentucky, and we need additional funding for screening purposes. And again, the amount is minuscule in nature. But I assure you, if we approve this request, the return on investment will be great. As legislators, we're vested responsibility of trying to control healthcare costs, if not reduce healthcare costs, and it's a challenge. But one of the greatest ways of doing that is investing in things that truly reduce the cost of healthcare, and that's what this does. I remind you again, we've given a $1 million appropriation to this program, and we're saving $67 million a year. So you can do the math yourself, and I hope you would support this request for additional funding during this next biennial budget. With that, Dr. Jones?
Yes, thank you very much, Senator, and thank both of you guys for serving on the advisory committee all these years. I just want to go through what it is for those people who may be new. The General Assembly established this in 2008, but although since 2000, multiple institutions have been working on Kentucky's colon cancer issue, but that's when the formal advisory program began. It had three main goals: increase screening. I think you've heard from Dr. Meredith that Senator Meredith, that we have done that dramatically. We've also saved about 270 people each year who don't die from colon cancer because of stage shift, and 640 people each year don't get colon cancer because we found their polyps and we skipped their cancers. And that is where the greatest cost savings is of that $67 million. And so that's really a key. The other piece is that when you look at the numbers, colonoscopy is a relatively, expensive intervention, but understand that this program is a catalyst for community health centers, FQHCs, those institutions that care for underserved and under-resourced individuals to get stool-based screenings, because in the past the excuse had always been, well, we're not going to do colon cancer screening because we can't ensure they get a colonoscopy if it's positive. That is the main impact of this, not just the folks that we screen, but all the people who are being screened out there related to the fact that this program exists. And, and unfortunately we see in the future a lot of proud Kentuckians, not signing up necessarily for benefits and insurance. They need an opportunity and an option to go to help prevent cancers. And so we've certainly met the goals there. I'm going to try to go to the next one. The eligibility guidelines are here, age 45 and older. And if you have a family history of colon cancer, and let me tell you, we have been the number one state in incidence for colon cancer in the nation for 2 decades. Thus, we have the highest burden of family-related risk for colon cancer and adenomatous polyps of any state in the nation. So this is critical that 45 become the finish line for communication, not the starting point. And we've really got to do a great job of finding those younger people and such. And I'll give you some data about that. They have to have a poverty income below 300% of the poverty level, be a Kentucky resident, and be uninsured or underinsured. And we do cover some people who have high out-of-pocket costs with high deductible plans, primarily for surveillance. Our partners through the Department of Public Health are as follows: the Kentucky Cancer Programs East and West, which are located at U of L and UK. This is where the universities are working together. One of the things that the legislature wants to see, doing a great job in terms of information. The Kentucky Cancer Consortium is our CDC associated person that works with us on grants and other things. And then the Kentucky Cancer Link, which is a nonprofit organization based out of Lexington that works in the breast and cervical and lung cancer and anything screening in Kentucky. The Kentucky Cancer Link is an unbelievable resource. I'll just brag on them. Most positive stool tests get a 70% conversion to colonoscopy. Kentucky Cancer Links is 98%, blowing the rest of the country out of the water because of the personal navigation that goes with it. And then the other part of the partners are those members of the advisory committee that sit on a bi-monthly basis and help us manage and work through that. And with that, I'm going to turn it over to Melissa Carr, who is the director of the Cancer Link, and we'll talk a little bit about the work that they've done.
I really appreciate the opportunity to be here and just come to you with the stories from the perspective of the boots on the ground, people that we're interacting with, each day. And as far as the Cologuard completion rate, we are able to have that high success because of navigation, but then also because of the safety net of the program, because if they qualify for the no-cost Cologuard, then they automatically are enrolled into the no-cost colonoscopy. So it gives that confidence for people to follow through with that next phase of screening. As you can see, over the years, we have really, worked hard to try and connect with hospital systems so that people can receive those screenings close to home. We have been able to have great coverage in some hot spots, especially in that eastern part of the state with our friends at ARH. But we do recognize that there are still gaps. And so fiscal year 2026, our goals are to really try to fill in there in the Pulaski, Adair, and Logan County areas. And our goal is to have a provider in each ad district so that people can get these life-saving screenings close to home. This is a graph. It is in draft session. It hasn't gone all the way up to the commissioner for fiscal years 24 and 25, but wanted to show the kind of the story of how things are going. So as you can see, in fiscal year 2023, we had a lower amount of colonoscopies, but we had an uptick in our Cologuard activity. So it actually helped us save some money in the Cologuard program. We did have a dip there in 24, but that was in 24, 25, there was a disruption in the contract. We have donated kits from Exact Sciences that we're able to provide at no cost. And then in 2025, we had a lower colonoscopy completion rate, but we also had to halt services as of May 31st, and we're not able to complete any services in June due to exhaustion of contracted funding. That being said, this first quarter, we've completed over 100 colonoscopies to date. So that shows that as the year goes on, and the projection is that we could potentially have up to a 50% increase in the services being provided, again, to those folks who are in the most vulnerable populations. We do have partnerships that work for alternative sources of funding, again, to be able to be conservative with the dollars that we are provided. I'm very proud of the colon cancer license plate. Go out and get one. And then also, as I mentioned, the donation from Exact Sciences, they donated 1,000 kits that we now that are getting our feet under us and have the confidence of the contract being in place are able to really start moving forward. We had a donation from Sevilla Pharmaceuticals for high quality prep that we could provide at no cost. And there should be an asterisk at the green square. We are in process of working with Guardant to be able to provide a Shield blood test that would be a kind of a last resort for folks that just won't do anything, that we can also then just have another tool in our toolbox to say, hey, this is important and we're ready to support you.
And so as we move forward, I just want to remind folks, Kentucky has the second highest rate nationally. Now we're 5th in mortality, so we're dropping out of that because we're preventing cancers and finding them earlier. But it is still the number 2 cause of cancer death nationally, right? And that's a really, really important thing. And unfortunately, still, we haven't been able to get as much uptake in that 45 to plus piece, particularly since it's new. 45 is relatively new compared to 50. So 1 in 3 adults remained unscreened that we can work on. And again, there's about 1.45 million people alive in America who are survivors. And we want more prevented, but also more survivors. But we face a different challenge in Kentucky, and this is a worldwide first world problem. Young colon cancer is dramatically up. And just let this sink in. The number 1 cancer killer for men under the age of 50 today in America and in Kentucky is colorectal cancer. By 2030, it will be the number 1 cancer killer in women, exceeding breast cancer. We do not know exactly what's causing this. We think it's environmental, epigenomic, microbiome. There's 200 different organizations around the world figuring it out. In the meantime, we already know enough to start educating people and really lifelong education for adults about colon cancer, like women receive lifelong education around breast cancer. And so that's really critical for us to educate the ecosystem, produce public service announcements, particularly in hotspots. UK and U of L are also working together on getting these maps where we can be very efficient in identifying and localizing folks with these high risks and really focus on these hotspots. And I want to commend U of L, UK, and the Markey Cancer Center and the registry for bringing good data together on set. And so just graphically to sort of roll there, at the bottom, those are the 17 states that report nationally on young colon cancer. And you can see that's going up dramatically. And the red is Kentucky. And we are 20 to 25% above the national guideline, and we are diverging. We are going higher than the national increase. So it's up to us. We know that by 2030 it'll be the number 1 killer. It is up to us to proactively and pragmatically in advance try to intercept this trend, not wait till it happens, and then say, oh, what are we going to do now? So now is the time for us to dig in on young colorectal cancer. And so as we sit here, we appreciate the opportunity to make that request for more funding to the legislature. The $500,000 annually has been put to good use, and our service is up dramatically. And again, I think 50% is very conservative. And so the demand is going to be exceeded. We're going to try to efficiently use all those donated services as well to optimize that blend, but also to provide some education through our trusted partners at the Kentucky Cancer Program into these hotspots. And so we're asking for an increase to $1.25 million annually, so $2.5 million over the biennium in order to meet the goals and the needs. And to really close it up, I think it's always best to talk about other Kentuckians. And Melissa, you're going to talk about this one, and then we're going to close with Representative Neighbors.
And just briefly, this is one of the many stories that as Kentucky Cancer Link, we get to interact with these people personally. And Mr. Bailey was kind enough to do a story about the program and highlight the importance of having state support and it was actually life-saving for him. So he was recommended to have one at 45. He put it off, and then he didn't have any insurance, and there was nothing wrong with him, but he went ahead and sought out assistance, and we were able to get him screened, and he did in fact have colon cancer, and now he's gone through the appropriate treatments, and he is now cancer-free. So Mr. Bailey is again just one story of the many that we're able to interact with each day.
So you've heard today from Senator Meredith, Dr. Jones, and Ms. Carr about the Kentucky Colon Cancer Screening Program, how it operates, and the impact it's having across our state. I'd like to close with why this issue is personal to me. Some of you may not know, but I am an early age onset colorectal cancer survivor, and I often think about how differently my story could have turned out if I had been uninsured or if I hadn't had access to a timely colonoscopy. Early detection saved my life, and I don't want anyone in Kentucky to miss that same chance. This program gives people that chance. It provides access to life-saving screenings for those who are uninsured or underinsured, the very people most at risk of falling through the cracks. It's not just a compassionate program, it's a fiscally responsible one. Preventing late-stage cancer saves both lives and healthcare dollars by avoiding the enormous costs of advanced treatment. Kentucky still has the highest colorectal cancer rates in the nation and one of the highest for early age onset. We can change that, but only if we invest in prevention, in education, on-time screening based on family history, and quick response to warning symptoms. That's why I'm asking for your support to increase funding for this program to $1.25 million annually. It's a small strategic investment with a tremendous return, protecting Kentuckians, saving lives, and reducing long-term costs to the system. No Kentuckian should ever lose their life simply because they can't afford or access a colonoscopy. Thank you.
Yeah, and we want to give a shout out to our partners at the Department of Public Health who administer this program and are tireless advocates in support of the program. Thank you.
Thank you so much. Do we have any questions from any of the members? Senator Burke.
Thank you, Mr. Chairman, and thank you guys for amazing work. My question is, why isn't this covered already by Medicaid?
It is covered by Medicaid, but there are many people who still are not Medicaid. A lot of proud Kentuckians have not been necessarily signed on to Medicaid. And so it is covered by Medicaid 100%. This is for people who are uninsured. Medicaid covers colon cancer screening according to multiple statutes we've passed. So stool-based screening, colonoscopy after a positive stool-based, or risk-based screening based on age, any age, depending on what your family is. So Medicaid does cover this.
And the statute that is in place for the eligibility is 300% of the individual income, so it's not household. So a lot of these folks are over the Medicaid limit that they can have access to it. And so a lot of them are self-employed, things like that have high deductibles that they aren't able to offset. So this is kind of a safety net. We see a lot of folks in that position.
Thank you. Thank you.
Just real quick for me to clarify, I think there's 500,000 now. Are we asking for an increase to 1.25? So an additional 750,000? Okay, I just wanted to clarify that. All right.
Yes, sir.
All right. Thank you so much for your presentation today. We'll move on to our next presentation. Next on the agenda is going to be an update for the Children's Home of Northern Kentucky. Then we've got several individuals to represent. Again, if you'll just share the microphone, please state your name and then begin your presentation. I will remind everybody we're doing pretty good on time. Everybody's doing okay. So we'll just continue to be mindful of that.
I'd just like for us all to introduce ourselves right
Please.
now. I'm Sal Santoro, board member of the Children's Home.
Rick Worth, CEO at CH&K Behavioral Health.
Hit the green button.
Health.
Try that one more time.
Okay. Crystal Loigers, Chief Programming Officer at CH&K Behavioral Health.
Julie Reyes, Chief Strategy Officer at CH&K Behavioral Health.
Thank you all for letting us be here. I guess I have public service in my blood. I've been on the board, and I'm happy to be here. I'm just going to be very short. Rick Worth is our CEO of the Children's Home. He has more than one hat that he wears, so he's just not the CEO. He does everything. He even pushes a broom.
Thanks. Sal's been a great addition to our board of trustees. It's wonderful to address you guys. I do come with an ask today, but I'm also very cognizant to the one, much has been given, much will be required. And so I'm hoping to give you also a report on how we've been able to utilize a prior state appropriation. But I taught high school for so many years that I know that I have to start the class lecture by talking about basic relevancy. How am I relevant to the problems that you good representatives and senators have to deal with every day? And I'll start just this way. There are hundreds of millions of dollars that you guys have to carefully manage. I'm thinking about things like student attendance rates in the Commonwealth. I'm thinking about the fact that Kentucky's below average in workforce participation. I'm thinking about our incarceration rates in the Commonwealth. I'm thinking about child abuse and child neglect. And I'm thinking about children in out-of-home care. And all of you have direct roles to play in every one of those matters. And I think I'm relevant to that. I think our team is relevant to that because so many of the issues I just mentioned to you seem to go back to two basic poisons in our drinking water in Kentucky, and that's untreated mental health issues and untreated substance use disorders. And so I would like to begin that way to explain how what I'm going to be sharing with you is relevant to you as a state representative or a state senator. And so you'll notice that we have a really bad name right now. We started off as an orphanage in the 1880s, and we've been taking care of the vulnerable Kentuckians who needed basic services since 1880. We transitioned at one point and we started providing care to the kids who are in state's custody because of abuse and neglect. And at one point, we adopted the name Children's Home of Northern Kentucky. If you look at the map, though, you'll see why that name does not reflect what we are doing today in 2025. We came to the bright idea, it took us a little while from 1880, but if you just take care of kids and you don't take care of the adults who take care of the kids keep coming back for more and more services. And so we made the strategic decision in 2014, we have to start caring for adults, especially those adults who have kids who are most likely to go into state's custody. And so the word children doesn't help. The word home implies residential only. Over the last few years, our biggest growth arena has been in outpatient services and in telehealth. So the word home is not very helpful. Northern Kentucky implies for so many people, Boone, Kenton, and Campbell. You can see from this service map, we're in 71% of the Commonwealth's counties with client impacts. 85 of the 120 counties of the Commonwealth have clients from CHNK. Part of the work that we are doing right now is a complete rebrand, and so we will cease being Children's Home of Northern Kentucky next month, and we will be adopting One Quest Health as our new name. And that One Quest is to transform America's health by approaching and embracing integrated mental health care that attacks and addresses those two poisons in the groundwater. So you can see from this slide, we have some pretty exciting increases just over last fiscal year. I won't read those to you. You can read yourself, but I'll tell you for this current fiscal year that we're in, ending June 30, 2026, we're on board for another 20% growth. And so what that will mean is 7,000 impacts and over 50,000 unique treatment services in those counties that you saw highlighted. Now, to the one who has been given, much will be required. And let me say, representatives and senators, I thank you profusely for the $6 million you appropriated in 2024. I will tell you this, it was the first appropriation that we've ever received since 1880. And so we were patient, and we are very grateful for that appropriation. And we've been spending it very strategically. And you can see here there are 5 buckets that we're strategically spending it on, from expansion of evidence-based treatment programs, growing our healthcare workforce with Northern Kentucky University. We are the only provider of psychiatric residential treatment facility level 1, PRTF level 1 care in the Northern Bluegrass region. That meant our buildings had to change. So facility improvements. The newest arena of care is virtual. And so major improvements in telehealth approaches, especially addressing counties in Kentucky where there's over 4,000 Kentuckians to some one mental health care professional at times in some of our counties. And then finally, how are we growing this healthcare workforce? Those are the strategic focus areas of that 6 million. I am a firm believer that government cannot be the answer to every one of our problems. We saw you as a solution to some of our problems. You gave us 6 million. And what I was able to do with our stakeholders in the private arena is to match that with an additional 9 million. So you gave us 6 million. We went out to the private sector and said, this is what our state senators and representatives have done. What will you do to match? And so 9 million. And you're going to see that those have been invested very strategically in programs, places, and in personnel.
So quickly, we'll just touch on that, we believe in more resources, more reach. And that has been our goal. We've made significant strides, and yet we can still see that the demand for services is far outpacing capacity. And so these statistics will probably be very familiar to you, but I will state just a few. We have 3.4 million Kentuckians living in mental health shortage areas. Nearly 70% of adults needing substance use treatment are not receiving it, and our emergency department visits are up 13% over the last 2 years due to mental health crises. And we know that the crisis is potentially deepening with the pending Medicaid cuts. So you're familiar with those statistics as well. We could anticipate nearly $2 billion loss in annual funding over the next decade. We're at risk of losing 35 rural hospitals and 33,000 healthcare jobs. At CHNK, we believe the transition to One Quest Health is our response to that. We need to bring innovation, and that innovation will come, as Rick said, by way of our people, programs, and places. We're starting with the workforce challenge, and we've developed a pretty extensive partnership with Northern Kentucky University by leveraging the healthcare workforce investment funds. We're looking at integrated care, as you've already heard. We know it's an emerging trend and necessary. It's going to produce better outcomes. It will produce smarter spending. And we're looking at our places, the digital first arena, as the next place for care. Crystal's going to give us a few more details.
So we knew as we were evaluating how we were going to move into this new arena that we were going to need the best and brightest associates in order to deliver high quality programs. And one of the ways that we're doing that is through a partnership that's very comprehensive with Northern Kentucky University. So there's 4 prongs to that partnership at this point. We have paid internships, we have full tuition scholarships, we have apprenticeships, and we also have an embedded classroom where One Quest Health associates are serving as adjunct faculty for NKU. So this is really exciting for us. It's been a significant pipeline already for associates, and we only anticipate expanding that through additional arenas. In terms of our programs, of course, Rick and Julie shared a little bit about our integrated care model, but this is a differentiated model from sometimes what we're describing as integrated care. We recognize that the complexity of the problems that we're serving require very comprehensive solutions. And so this is not just a collaboration between primary care and behavioral health. We're examining root causes, so we're looking at things like sleep hygiene, we're looking at nutrition, fitness, prenatal care and substance exposure, and socioeconomic factors to ensure that we're getting to the root of the problem so that not only can we consolidate the length of stay because of the comprehensive assessment, but we're establishing a foundational plan for that child, that family, or that individual that will serve them in the long term rather than band-aiding and providing a revolving door for residential treatment. And then examining our places. So as we've mentioned, this collaboration between behavioral health and primary care and this multidisciplinary approach really does require upgraded facilities. And we want to ensure that we're able to have the foundation of facilities in order to provide these services. In 2024, we also added our 4th location in Grant County, and that was just the beginning. We recognize that 61% of Kentucky's counties are still in professional shortage areas, and we want to serve that need, both through physical plant locations, but also we recognize that a very important venue for our services is virtual through telehealth to expand access, and that's going to require an additional investment in those digital first strategies.
So here's the ask. We brought in consultants from around the country to help us make sure that we were thinking clearly about how are we moving services upstream. We do not want to be continually reactive. We want to move upstream with services at the right place at the right time. And these consultants also helped us to address a huge problem, and that is the number of people that we have on our waiting list. This morning, there are 400 kids on our waiting list, primarily in outpatient services. And so we knew that that was not appropriate, especially for someone who needs mental health care services. You cannot place someone on a 5-month waiting list and expect no problems to happen. There will be problems with a 5-month wait. And so these consultants helped us to put together a $38 million plan to recreate CH&K into One Quest Health, to work on those 3 focus buckets that Crystal just spoke to you about, and to create an infrastructure that was aimed at addressing the quadruple aim of healthcare. We wanted not to come to you with the entire $38 million ask. We decided that a public-private partnership was the strategic way to go. And so we came in 2024 and we asked you for a $19 million appropriation. You graciously gave us 6. We're now coming back to ask for the remaining 13. As I shared with you, we have done a great job of leveraging the private sector, and we will continue to do that again. Out of the $38 million goal, we've now raised $15 million. If you will see fit to give us the remaining $13 million, then I have $10 million to leverage from the private sector, and I am confident in our abilities to do that. What will be the result? Fewer kids sleeping in DCBS offices, fewer Kentuckians incarcerated, fewer Kentuckians not participating in our workforce programs. Those are the Kentucky uglies that we feel that we are here to help you with. I thank you for your time.
Thank you so much for all the presenters today. Do we have any questions from members of the committee? Senator Moser, or Representative Moser, thank you.
Thank you, Mr. Chairman, and thank you very much for your presentation. I really don't have a question. I just wanted to acknowledge the work that you've done in our community and across the state. Clearly, by the map that you showed us, you're doing work across the state, and I just want to applaud you for the transformation that you're seeking. I think it'll serve more and more families. And I fully support the work that you are doing. And I do want to add, you didn't mention the great work that you're doing in kind of that hub and spoke, creating partnerships across the region, across the state that we have talked about over the years. So thank you for creating those partnerships and really lifting everyone up in our region. So thank you for doing that. And thank you for your work.
Thank you.
Representative Mosier, thank you for everything that you do for our Commonwealth and for Northern Kentucky. And you are exactly right. This new infrastructure that we have designed is not just good news for our institution. We feel that it creates a dynamism and an infrastructure model so that others can participate in what we know is replicable around this Commonwealth.
Any other questions? Or Representative Fleming.
Thank you, Chairman. First of all, I appreciate you coming up here or coming down here since y'all in North Kentucky. Get my directions corrected. When I was up there this summer, y'all were very, very nice to embrace me and to give me a tour and give me sort of a a monumental task ahead of you, but I think you've got the infrastructure from a personnel standpoint and the creativity in order to make that happen. So I do want to express my appreciation for what y'all have done thus far and your outreach to the whole Commonwealth. And I applaud you for, I guess, rebranding yourself in order to get out of the mode of being sort of siloed. So I do appreciate that. If you don't mind, could you just go through and give me sort of a tick mark of itemized the 30, you said 38 million, correct? How's that lined up? Like, how much is the match? How much have we given you? Just sort of restate that for my own edification.
Yeah, absolutely. And Representative Fleming, thanks for the visit that you made to us and for the insightful questions that you provided to us during your visit. So the campaign is a $38 million campaign. There are 3 major buckets for that focus area. And those focus buckets are, first of all, personnel. How do we attract the best, most talented healthcare providers in a Commonwealth right now where those providers are few and far between? And what we decided was we had to grow our own crop. And that includes a very strategic partnership with Northern Kentucky University. The second bucket was related to evidence-based programming. How do we know that the interventions that we are undertaking for kids in state's custody who are in our PRTF programs, how do we know that the interventions in our adult IOPs, partial hospitalization programs, are truly effective? And so massive amounts of spending on evidence-based only programs. If it's not evidence-based, you will not find it at OneQuest Health. And then finally, the third piece, sometimes it's less exciting, but it's so critical. In our past days, we were licensed as a private child caring institution. We took care of kids in state's custody who needed 24/7 care. What we realized was that there was no one in northern Kentucky, in the northern bluegrass region of the Commonwealth, willing to do psychiatric residential care. The acuity issues are more intense. And that meant we had to introduce to this $38 million campaign some real important features related to physical plant. I'll give you one example. We can't have residential toilets in our facilities. The kids would sometimes take the toilet tank lids off of the residential toilets, crash them to the ground, and then use the shards of the toilet to attack other kids or to attack staff. And so the bathrooms in our facilities are now psychiatric hospital grade facilities that you would find at a place like Cincinnati Children's Hospital Medical Center. Those are the 3 primary spend areas. You gave us 6. We matched $9 million in private funding for that. We're now coming back asking you for $13 million, and then the pressure that puts on me is to go out and raise $10 million privately, which I'm committing to do. I hope that answers your question, Representative.
It does, and thank you. I just wanted to get some clarifications, and I applaud you for going out in the community to raise those funds. Obviously, we always I'm always an advocate of public and private partnerships. Yeah. And I think when I was up there with you all, I mentioned about House Bill 200. That is a great way to really even leverage more in terms of what you're trying to achieve, because I know from a mental health standpoint, there are few and far between, and that's what we're facing on the Medicaid Oversight Board. Yes. The inadequacy of healthcare providers comes back to reimbursement rates. People don't want to get into the process because they can't get paid, and so they're going to go somewhere else. It's a vicious cycle. Yes. But I think, and I do, like I said, I do appreciate your efforts in doing a public and private partnership, and I wish you all the luck in on that endeavor. So y'all got a great model and a great program, and I wish all the luck to you. Thank you.
Thanks, Representative.
Thank you.
Representative Williams.
Quick question. Thank you, Mr. Chairman. So going over the budget and looking over some of the numbers, one of the most expensive things we have is residential treatment.
Yeah.
How would this investment cut down on that time frame, and will it keep more kids out of the residential setting and off of that large number?
I'm so grateful for that question. Thank you. And that was certainly a primary factor as we were evaluating the expansion of OneQuest Health and how we can address some of the needs, because we've certainly been part of a number of these conversations as we shifted from private child caring to psychiatric residential treatment facility. As I mentioned a little bit in the presentation, one of our primary goals is to reduce the length of stay while enhancing the service offerings. So currently our average length of stay in residential is 90 days, and our goal through these enhanced service offerings is to get that down to 45. And the goal of that is two-pronged. One is to enhance access, and also we recognize that being in residential care is not good for kids. It always represents a trauma. And so because they're separated from their family of origin, they become integrated into a residential way of life, and it's difficult to reintegrate. And so if we can reduce our length of stay by half, that expands access, and it expands the opportunity for additional constituents to have access to those beds and doubles that. So we don't have to increase the amount of facility beds we have, but we can expand access and be able to widen that breadth of provider, or of the children that we're able to provide services to. In addition to that, of course, as Rick mentioned, we're really shoring up our outpatient pipeline so that then there's also a catchment for those children and stepping down either through telehealth or through our outpatient offerings to make sure that there's intensive services that are able to get them back into the community with the support that they need.
Representative, if we're successful, and I believe we will be, I don't think this is going to be overnight. I don't want to mislead you that we're just going to do this at the click of a button. It's going to take some work to reduce our average length of stay by 50%. We are not doing this on the fly. We have teamed up with one of the largest providers of mental health care services in the Pacific Northwest, and we have flown them in continually over the last year, and we asked them a basic question: how did you do it? They were successful in reducing the length of stay by 50%, and so we're holding their hands carefully and learning as we go. If we are successful by reducing the average length of stay, this one institution alone can save Kentucky Medicaid taxpayers $2 million a year. And so we are very cognizant of the fact that there are going to be fewer Medicaid dollars. We know the answer about higher Medicaid rates, and so we have to do more with less. And that's what we're committed to do.
Thank you. I appreciate what you do in that field. It takes a special group of people to do it, and I appreciate what you do there. Thank you.
Thank you.
Thank you.
All right, thank you. Thank you so much for your presentation, your presence today. All right, the last item on the agenda is an update on the Kentucky Lung Cancer Screening Program. We'll have Representative Kim Moser and Dr. Timothy Mullett.
Yeah, I'll start. Okay. All right. Thank you, Mr. Chairman. Thank you, committee, for giving us a few minutes to provide an update on the Lung Cancer Screening Advisory Committee. This was legislation, House Bill 219, that was passed in 2022, making Kentucky the first state in the nation to pass this legislation, creating a lung cancer screening program in the Department of Public Health. House Bill 219 established a program with the goals of increasing lung cancer screening, reducing morbidity and mortality from lung cancer, and eventually reducing health care costs associated with the treatment of lung cancer in the Commonwealth. Additionally, this legislation established an advisory committee composed of stakeholders, advocates, and experts in the state to provide guidance and strategic direction for the program. And before I go on, I forgot to introduce myself for the record. I am Kim Mosier, State Representative, and I will allow my guest to introduce himself.
Good morning. I'm Tim Mullett. I'm a thoracic surgeon in Kentucky for nearly 30 years, and appreciate the opportunity to be able to share with you the importance of early detection in lung cancer.
Thank you. And so why did we need this program? Well, Kentucky ranks first in the nation for the prevalence of lung cancer. especially with an age-adjusted incidence, this is with an age-adjusted incidence rate of 84.8 cases per 100,000. This is significantly higher than the national prevalence of 54.6%, or 54.6 cases per 100,000. As grim as this statistic is, the prevalence of lung cancer cases has improved by 14% over the past 5 years. The leading risk factor for lung cancer is smoking. Kentucky ranks 4th in the nation for adult smoking, with 1 in 5 people indicating that they currently smoke cigarettes. The second leading cause of lung cancer is radon exposure, which is also particularly high in certain areas of our state. Other types of exposure can increase lung cancer risk, including exposure to wildfire dust, or wildfire smoke, and occupational exposure to diesel exhaust and silica dust. Current guidelines from the United States Preventative Service Task Force recommends annual lung cancer screening for those who are ages 50 to 80 and have a 20-pack-year history of smoking, and either currently smoke or have quit within the past 15 years. Studies show that annual lung cancer screening can reduce mortality by 20%. If caught early, in the localized stage of disease, then 6 in 10 survivors will be alive 5 years later. If caught in the later stages of disease with metastases, the 5-year survival rate drops to 8%. Unfortunately, only 27% of lung cancer cases are caught at the early stage, and this is when we have the best chance of survival. And catching those early cancers is really the goal of this program. We had an appropriation of $500,000 in the past 2 budget cycles, and we would like to increase that to $1 million to continue to expand this program. And I, at this point, will hand this over to Dr. Mullet to talk about some of the great successes of this program. So thank you.
Thank you very much, Representative Moser. I'll start by saying that as a thoracic surgeon, and the numbers that you heard, I am frustrated by the fact that when we look at treating lung cancer, and we know that we have curative intent with surgical operations that can be successful for so many patients, but we see so few of the patients in that stage where we can actually make a difference. And so our whole opportunity here is to migrate these patients from this dramatic mortality and late-stage disease, despite the increases and successes of targeted therapy and other advantages that are coming, move them into that early stage where we have that opportunity for successful treatment. You've heard great stories from the colon cancer screening program. You've seen evidence from breast cancer work. And we've moved many, many patients into early stage in these diseases, and they're continuing to make great strides in that area. Lung cancer has the most significant impact on cancer mortality. And if we are able to move patients into the earlier stage, we will have dramatic reductions in in not just lung cancer mortality, but because of its impact over all cancer mortality. It is responsible for the deaths of more patients than colon cancer, breast cancer, prostate cancer, pancreas cancer combined. And so we have not put that much emphasis on lung cancer in years past, because until 2011, when we had the results of the largest randomized controlled trial performed in the country to give us the evidence to reduce lung cancer mortality by 20% in those early stage patients. And then in 2015, it was approved for coverage in Medicaid, Medicare, and all commercial payers. But yet we still have slow uptake of lung cancer screening. And that's what we're really trying to affect here, is we're not patient to be able to wait for 30 years to be able to see us move into an area where we can save more lives. So I want to tell a brief story of how we've been working on this for several years, and I represent a team of folks that are broadly across Kentucky and now across the country and taking this story to be able to have an impact. But you have to understand that we are treating an area of the country that is the highest risk for lung cancer and for lung cancer mortality. We see a dramatically rural population across our state, and Kentucky represents particular pockets of high-risk cancer, but all of the state is higher than the national average. We've developed networks, we've developed opportunities to be able to influence delivery of high-quality cancer care and fight against these challenges that exist: persistent poverty, also high tobacco use in Kentucky compared to the rest of the country, decreasing. That's wonderful. Decreasing at a rate faster than the rest of the country. That's great, than other areas of the country at least. So we're no longer number one. We're now number 4 or 5, and so that's great. But if we're going to influence mortality in lung cancer, we've got to shift stage. If we want to influence incidence, the number of cancers that are developing, we can continue to work on tobacco, radon exposure, other factors. But if we want to introduce a better mortality, we have to move these patients into early stage. But other risk factors such as low education and socioeconomic factors keep patients away from some of these opportunities. Again, the hotspot of Kentucky is represented here, highest in the country, and the entire state is represented above the national average. And while the state represents 85 per 100,000, certain areas of our Commonwealth are well over 100 per 100,000, and we need to make changes in that. The NCI, National Cancer Institute, asked us several years ago, what are you doing about your lung cancer problem in Kentucky? And so we wanted to be able to address that, and our group combined from the College of Medicine at the University of Kentucky, the College of Public Health, and now from even University of Colorado, have been able to help to be able to work together for over 10 years to tell a story that is promising, that began in 2013 through private funding through the Bristol-Myers Squibb Foundation to lead us into a program called the Kentucky Leads Collaborative, which ran over several years to be able to evaluate lung cancer screening programs, combining with numerous state and national organizations you see represented here, ultimately to be able to lead to the success that I'm going to tell you about. So this is a multi-pronged approach to be able to address lung cancer screening. In 2021, we were in a publication that represented Kentucky as the second state in lung cancer screening, meaning that we had achieved over 16 or 17% of eligible population getting screened, second in the country compared to the national average of around 6% at the time. The numbers have increased, and we are now over 20% by certain measures, and we remain a leading state in the country. But our story is strong in the fact that we are working in the highest risk population. I do want to say that when we began our project with these communities that are listed on the left lower area of the slide, we began looking at lung cancer screening programs and addressing aspects of lung cancer screening to try and get more patients in and to keep them in the program, because the way that patients save lives, that programs save lives, is for patients to come in and get screened once, and then to get a relationship with that program and come back and get screened again and again and again, year after year. And that's where we find early stage lung cancers. And so when we looked at our program several years later, we were able to identify where our program was initiated. We saw the higher levels of lung cancer screening rates, as high as over 22%. And so we recognized that our influence was making a difference in driving lung cancer screening forward and achieving such high rates. Even in areas where we didn't initially perform our studies, we went back and went to this area and have seen continued increases in these rates as well. And so how we achieve this, even in the environment where Kentucky stands out as achieving high rates of lung cancer screening, but we have the highest burden. So it's critical for us to be able to continue to excel and move past what is now only 1 in 5 eligible patients getting screened and achieve the rates that we see with colon cancer and breast cancer and others to get up to that 70, 80+% of the eligible population. From our work, we've seen a decrease in late-stage diagnosis in lung cancer. These are patients moving from that late-stage, high-mortality group into that early-stage group. And this is a way to look at this as a leading indicator of mortality, decreasing late-stage diagnosis. Kentucky, in the blue line, is decreasing twice as fast as the rest of the country. And in the green line, Appalachian Kentucky, where we have the highest burden, we're decreasing at a rate 3 times faster than the rest of the country. So our work is paying off, but we have a lot of work to do. Another way to look at this is in our study, we began to look at the ratio of early stage 1 to late stage 4 lung cancers. And so in this ratio, you can see on the left side of the chart that all of us, the national numbers in red, the rest of Kentucky in green, and the sites that participated in our study in blue were all about the same. 60% of the patients being diagnosed with early stage disease compared to late stage disease. And that's been consistent for decades. With the influence of education and with the influence of our implementation of our strategies to improve lung cancer screening programs, Kentucky improved. The rest of the country did not dramatically. And so even in our sites that were not participating in our study, our education program was effective. But when we were able to implement our strategies to drive lung cancer screening deeper into the community and develop those relationships, we've seen persistent increases in lung cancer screening, leading to effective shift to stage 1 disease. So these are patients that can now successfully have an operation or targeted therapy to be able to treat those patients more successfully for dramatically lower cost. When we wait and we treat patients with late-stage disease, it may be $400,000 or $500,000 compared to the cost of an operation and a short hospital stay of a couple of days now, and getting that cost down to $20,000 or so. You all have supported us dramatically. Representative Moser mentioned the success of the legislative session in 2022 to bring House Bill 219 into law. You also supported us with lung cancer research funding in 2000. Wonderful opportunities, leading the nation in this opportunity, and I think we need to continue to drive this forward in a state that has such a burden. Furthermore, we've been able to take what we've done in Kentucky and through private funding through Bristol-Myers Squibb Foundation, we've been able to move this to other high-risk states such as Nevada and Mississippi, and now we've been funded for an NCI grant to be able to take this in other areas across the country. So our work is not finished here in Kentucky. We've continued to work on numerous contracts within the Kentucky Lung Cancer Screening Program that you all have funded to be able to drive us to see success in bringing resources to drive our Quills program into at least 16 programs, again, in Kentucky, but also collaborate with the Kentucky Cancer Program, East and West, connect with the Kentucky Cancer Link, connect with understanding the environment of lung cancer that we take care of using social marketing tools. And so this is important for us to be able to drive forward. And by doing this work, we've actually been able to see that Kentucky is moving from not number 1 anymore, in men at least. We are now number 2. And so I think this is an imperative that we see that this is moving us from where we were a distinct outlier as number 1 to now moving into this number 2 range for men, and clearly expecting that we're going to continue to drive this further because of these efforts. But we cannot continue to support all of the contracts that we have within the Kentucky Lung Cancer Screening Program with the funding that we have right now. And so our opportunity exists for us to be able to increase that funding so that we can be able to have more of an effect over more of our population and be able to continue to see these influences even more dramatically.
Thank you so much for your presentation today. We do have at least one question. Representative Wildner.
Thank you, and thank you for the presentation. This is really good news, and I really wanted to make a comment that was just more general, and it was to thank you, Mr. Chairman. This was a great agenda today, 4 really strong presentations, and 3 of the 4 were really focused on moving interventions and our attention further upstream. and we're seeing what a difference that makes already. And as stewards of the public dollars, I just think that this is the smart approach, the right approach. We're already seeing these great effects. And so I really just want to thank you for selecting this. And I hope that as we put together our health services budget, that it is going to be largely focused on these upstream programs that are already working. So thank you.
Well, thank you. I'm not going to take credit. This is very much a work of everybody else in the General Assembly, from Representative Neighbors to Representative Moser and everybody that's really kind of pitched in to bring the people they represent to the table. So thank you for the compliment, but I'll put it back to everybody else. Thank you for everybody else's hard work and the staff, especially for coordinating everything. I do have just a quick question, probably for my clarification. I'm gonna use the new guy card as long as I can. Currently from tobacco funds, correct? Are we asking that any additional come from the tobacco funds, or are we talking about general funds?
We are not specifically asking for this appropriation to come from the Tobacco Settlement Fund. It doesn't, the way the Tobacco Settlement Fund works, it really is not as specific to tobacco use as I would like. I know that there are some initiatives coming forward to set up a trust so that some of those funds will address vaping and teens and that sort of thing. But this appropriation is a general fund request.
Okay. Thank you for that clarification.
Yes, thank you.
Any other questions? Okay. That will do it for today. Thank you again for everybody. Before we adjourn, please note that our next meeting is going to be November 5th. That would be our last meeting of this interim. And then also there is EKU has a health forum and luncheon in room 125 that I think is still going on if you want to slip in there. Thank you very much. And do I hear a motion to adjourn? All right. Thank you.